Hi, Colleen. We're live.
Thanks so much, Ellie. Well, I want to welcome to the members of the public tuning in for today's Market Oversight and Transparency, affectionately known as MOAT, committee meeting. My name is Colleen Elstermeyer. I'm the Deputy Executive Director of the Health Policy Commission, and I am joined today by members of our MOAT committee, Commissioner David Cutler, who chairs the committee, Commissioner Patty Haupt, Commissioner Ram Mastergiovanni, and we are awaiting our ANF designee, Commissioner Kwasnick. Also welcoming HPC Chair today, Deb DeVoe, who is joining us, and Commissioner Blakeney, who chairs our Care Delivery Transformation Committee. So welcome. Very pleased to have a full contingent of commissioners to kick off. In a few minutes, I am going to be turning this over to our excellent HPC staff and our Chair Cutler. But I did want to let everyone know that you will be missing a familiar face today. Our Executive Director, David Seltz, will not be attending this meeting. He is at a meeting in Denver, Colorado, with the other benchmark states to share learnings and lessons from Massachusetts. So he will be logged in, but he will be remote from Colorado, so not actively participating. So did want to let you know that at the top. And I am really excited. We have a grab bag of goodies prepared for today's meetings. We're going to divide the meeting into 3 one-hour blocks. So MOAT for 1 hour, and then a special presentation for an hour. And then our Care Delivery Transformation Committee will be the final hour. So several important topics to cover today. First, we're going to be talking about ambulatory surgical centers in Massachusetts. Then our staff is going to give you 2 updates on federal rules. The feds have released the final rule on the automation of prior auth. And then another recent federal rule change has come down on DOJ, FTC merger guidelines. So that's the second agenda item. We'll talk about what that all means for our work in Massachusetts, very important. Then at 1 p.m., special presentation from EHS on the important push they're spearheading to advance health equity in Massachusetts. And then I won't go through the agenda items for CDT, but they are exciting and they will be great. So Chair Cutler, turning it over to you for any opening remarks before we dispense with your favorite topic, the minutes.
Colleen, thank you. And it's great to see you. And I suppose with David not being here, we can say all those things we've been meaning to say at all the previous meetings, but haven't been able to do. Probably the most important of which is maybe we should approve the minutes.
Let's do it.
So we have all been circulated the minutes. I suppose we need someone to move that we approve them.
So moved.
And then a second for them.
Second.
Does anyone have any changes, additions, or deletions? If not, if I recall correctly, we need to do a roll call since we're on Zoom.
Yes. Would you like me to call the roll for you?
That would be wonderful. Thank you.
Okay, I'll start with you, Chair Cutler.
Approve.
Commissioner Haupt.
Approved.
Commissioner Mastergiovanni.
Approved.
And Commissioner Kwasnick.
Approved.
Thank you so much. So our first agenda item today, Chair Cutler, I know you'll be thrilled to hear we're releasing a report from our next issue of HPC DataPoints. This is the 26th issue. Our commissioners know very well this is our online publication series, spotlights new research, new findings on any number of relevant health policy topics through interactive graphics on Tableau. So that's what makes it unique. So throughout the meeting, just want to note at the top, and starting with this agenda item, all of our topics will be tied back to our policy recommendations that we issued in September. And you'll all remember that in that cost trends report, we did examine prices at different sites of care, noting growing hospital outpatient utilization. So we decided to take a look at ambulatory surgery centers, the regulatory context that's shaped the industry here, and what is driving pricing and utilization of ASC. So, Chair Cutler, turning it over to you and turning it over to Sarah Sadownik, our Deputy Director for Research and Cost Trends, to begin the first agenda item.
I think it's quite fascinating. So Sarah, we're all looking forward to it. And why don't you just take it away?
Great. Thank you. Good morning, everyone. So, we're going to be talking about trends in ambulatory surgical centers today. And as Colleen set up for us, the impetus for this work was our findings from our last cost trends report, where we showed hospital outpatient departments as a major driver of spending. And we reviewed differential pricing at alternative sites of care, including urgent care centers, and also preliminary work that we had in the cost trends report on ambulatory surgical centers, or ASCs. So we've taken this landscape analysis approach in the past on other sites of care, including urgent care centers, and felt that this was an important area for similar landscape analysis. So as background on the industry, ambulatory surgical centers are freestanding facilities that are capable of providing non-emergency same-day surgeries. So they provide low-risk procedures, which would mostly otherwise be done in hospital outpatient departments, or HOPDs, although they there is a subset of the most minor procedures that they do, where those procedures could also safely be done in an office setting. So ASCs are entities that specialize in particular areas. Some specialize in procedures in a single specialty, such as ophthalmology, or a subset of different specialties. So they're multi-specialty, perhaps 2, perhaps 3, 4, etc. The top specialty services nationally are orthopedics, ophthalmology, endoscopy, pain management, and the literature, where available, suggests that quality outcomes at ASCs are comparable to HOPDs, and in some cases better. Some studies have found, although most studies caveat the need to appropriately select patients for surgery at ASCs based on the complexity of the case. So the more complex cases should be done in HOPDs. And we have some details and citations to the literature on quality and safety in the data points that will be released today. So in terms of other important aspects of the ASC industry, nationally, almost all, about 95% of ASCs are for-profit entities. The majority of them are owned by physicians, either solely owned by physicians or partnership between physicians and hospitals, and in some cases, physician hospitals and corporations. So physician owners can earn income from the profits of the ASC, in addition to, sort of direct professional fees if they are the ones performing the procedure. Importantly, ASCs are exempt from the federal physician self-referral law, known as the Stark Law. So, for example, a surgeon who works in a HOPD and is a owner or co-owner of an ASC is able to refer a patient to an ASC that they own. In terms of prices, in our previous work, we've found that ASCs typically have lower commercial prices for their services compared to if that same service was delivered in a hospital outpatient department. And both Medicare and Medicaid pay lower rates for the same services in ASCs. Next slide, please. Oh, great. One step ahead of me. So turning to the Massachusetts landscape.
Could I ask a
as
question?
Of 2000.
Could I ask a question quick, please?
Sure.
The firms
Sure.
that they own, are they C Corps or S Corps?
Oh, Commissioner Master Giovanni, that is, I don't know the answer to that question. I think, but we can certainly look into that, into those sort of financial details and get back to you.
Yeah, I brought it up because when you mentioned that they can generate income through the corporation as well as how they would normally get paid, that's why I brought up S Corp versus C Corp, because there are potential benefits between the two. That's something to check.
Okay, great.
We can look at that, whether it's professional corporations or an LLC, something like that. We'll take that back.
Great. So in Massachusetts, there are 58 ASCs that are licensed by DPH. 54 of those are also certified as ASCs by the Center for Medicare and Medicaid Services, which enables them to receive Medicare payment. the discrepancy between the DPH list and the CMS list is probably mostly due to just sort of technical details of when the lists were compiled and sort of other technical details. In total, the facilities in Massachusetts have a total of 160 operating rooms. And we wanted to note that, like hospitals, ASCs also pay an annual assessment that funds the HPC and CHIA. In terms of specialties, in Massachusetts, those are similar overall to the top specialties in the US, including orthopedics, ophthalmology, and endoscopy. About 90% of the ASCs in Massachusetts are for-profit, and similar to the national landscape, most ASCs in Massachusetts have partial or complete physician ownership, including joint ventures between physicians and hospitals and or management companies. So the presentation that we'll cover today and the data points that will be released are covering a number of important topics in the landscape, including the location and the services provided, who's using them, and trends in relative utilization, and prices and spending. Next slide, please. So Massachusetts has among the fewest ASCs per capita among all the states, the fourth fewest. We have an average of 8 ASCs per 1 million population compared to a national average of 18. We also looked at the number of operating rooms in Massachusetts versus the US to investigate, well, maybe the size of the ASCs are different. But that isn't the case overall. Even accounting for operating rooms, the trends are similarly far below the national average. In Massachusetts, there's an average of 23 operating rooms at ASCs per 1 million residents compared to a national average of 56. So, looking at this graph, it begs the question, why is there this difference? Well, in considering the variation between states, the Medicare Payment Advisory Commission concluded that the primary driver of variation by state in ASC volume is the regulatory environment in the state. And they highlighted that states with determination of need laws tend to have fewer ASCs than states that don't. So we'll turn to that regulatory history in Massachusetts on the next slide. Okay, this graph shows the number over time to today, the number of ASCs that opened, the number of ASCs that closed, and in that blue line, the cumulative number that were open in any given year to today. So looking at this graph, we'll see that the early 2000s were a period of rapid expansion in the ASC industry in Massachusetts. That changed in 2008 when Chapter 305 of the Acts of 2008 removed the physician group practice exemption. Under this exemption, ASCs that were wholly owned and controlled by physicians had been exempt from regulations that required approval under the DON program. Now, with that exemption removed in 2008, new ASCs needed to seek clinic licensure and obtain DON approval, which effectively resulted in a moratorium on new ASCs. And as you can see, starting in 2008, 2009, the number of ASCs in Massachusetts plateaued. The next biggest change was in 2017, when DPH amended its regulation, to lift that moratorium with certain new requirements. Those requirements were, one, that an ASC needed to have an affiliation with an HPC certified ACO, accountable care organization, and two, if an ASC planned to open within the primary service area of an independent hospital, the hospital needed to grant approval. And since most ACOs in Massachusetts are operated by or affiliated with hospital systems, both of those requirements effectively result in the need for hospital approval of most new ASCs. And while there are certainly exceptions overall, hospitals may be reluctant to grant approval since ASCs often compete with HOPDs for patient volume, of course, with exceptions. So looking at that blue line again, we can see that while there have been new ASCs that opened after this time, we do see a continuing of the plateau in the number of ASCs in Massachusetts to today. So with this background, unless there are questions at this point, I will turn to Katya to walk through our data findings.
Sorry, Sarah, can you just help us process a little bit? If you go back to the slide which compares Massachusetts and the rest of the country, if we were at roughly average, we would have at least twice the number of ASCs. Is that right?
That's right, more than twice.
And if you, I know, like, I'm trying to think if anyone's done any studies. I'm not aware of any on like, have states that have been more permissive in ASCs had fewer inpatient hospital beds or fewer inpatient facilities. Like I don't, nothing jumps to mind, but I'm trying to think of what would happen if we were to just say, hey, let's have more ASCs. Would we say, oh, gee, we just don't need that many hospitals, you know, because we can put ASCs in places and stuff like that.
You mean sort of in terms of a substitution effect with hospices, or so whether it's
or with inpatient centers, right? Because you know, once you take the surgeries, you know, once you take many of these elective surgeries out of the inpatient center, some of them may not have enough volume and just close.
I'm not sure about. I'm not aware of sort of direct effects on inpatients, since these are all, you know, pretty low risk outpatient procedures that don't, you know, that sort of wouldn't have direct crossover with inpatient. I believe, and Katya, let me know if you have seen other literature, but I think sort of the, you know, sort of a concern of, is there going to be sort of you know, sort of supply induced increase in demand for total services, I think has not really borne out in other states. It's more of a substitution. Are there other questions, or did that answer your question?
No, you know, it does. I just like, I should look through the literature and see, you know, what is there any literature on what is the net impact of having more ASCs?
Mm-hmm.
You know, because we have these, you know, these various state laws, and one could certainly look at them and then say, you know, what do people find is the impact of more lenient versus less lenient entry of ASCs? And like, I should know that off the top of my head, but I don't. So I'll try and ask around.
We can definitely look into that too. I think you're trying to draw the conclusion. I think it's certainly fair to say that the legal and regulatory history here has certainly shaped and impacted the proliferation of these types of sites. And this is the current state that we're in, looking at this landscape. So, I mean, we're happy to take a look at that too. All right. Katya?
Oh, wait, Ron also has a question.
Oh, Ron, sorry.
Yeah. What I find interesting is I support regulations in this area, but to have a regulation where you have one company, I'll call the hospital a company, have to approve a competitor, that becomes that becomes quite difficult in terms of how that could be done, and what the ASC has to give up in order to run that operation. And then the other interesting thing that comes up is when you look at ownership, you have, I don't know what percent are wholly owned by physicians or partially owned by physicians. Does the physician have a minority position or a majority position? That has an impact on how that stuff gets run as well. All right, so this is very interesting to get into a little more detail on how that's structured. And I think David brought up some excellent points in terms of, given the number facilities that we have in Massachusetts. How would things improve if we had more? Is that something that we should be looking at and looking at potentially recommending a change in the regulations?
Thank you. Lois?
Can I just add that, is that, I sort of agree with all of you. I'm thinking, would that be able to decrease cost of healthcare if we were to have more, as an overall piece? And that's, if we're looking at that, I sort of find that very intriguing.
Absolutely. I saw Lois piping in to answer Ron's question, just to say that we know there are potential changes to the DON process that the Department of Public Health is looking at right now. The legislature is also considering changes. There's DON reform in Speaker Mariano's bill, which was refiled this session by Chair Lawn. So there's obviously leadership support for these types of changes. So that's definitely on the table, Commissioner.
And to your point, Dr. Castile, about the impact on spending, I think the next set of, well, the results later in this presentation on price, I think will speak to that.
Thank you.
Great, let's turn to Katya. Next slide, please.
Good morning. As Sarah noted, the number of ACs per capita in Massachusetts are less than half of national average. And this exhibit shows you the same statistic, ACs number per million residents in Massachusetts and in what is common national. And as you can see, Massachusetts is far below national average in every single service category. Even the specialties that are most common for Massachusetts, such as ophthalmology and GI and endoscopy services, they are only about half of national average number. And the orthopedic services that are most common nationally at 6.7 ACs per million of residents, in Massachusetts, we have only a quarter of that number. And other services are also a third to a quarter of the national numbers. Next slide, please. This map shows the geographic distribution of ACs in blue and acute hospitals in red across the state, and demonstrates that ACs can be found in every corner of our state, from Berkshires to Cape Cod. You could see that ACs are mostly concentrated around population centers and generally follow the geographic distributions of acute care hospitals in the state. And it's possible that the location of ACs were influenced by 1994 DPH regulations that required ACs to be located within 15 minutes of acute, or within 15 minutes of travel time from acute care hospital. And right now, this requirement is no longer in effect, but historically, it might have impacted where current ACs are located. Next slide. This map also shows the locations of ACs, but it shows them by service category, and it also shows multi-specialty ACs. The most common type of an AAC is an eye surgery centers in blue here. There are 18 of those located also in every corner of the state, and in addition to the single specialty, there are additional 6 ACs that provide eye surgeries among other surgeries that they have. Another common category for Massachusetts ACs is GI endoscopy centers, and we have 12 that specialize just in that, and in addition to that, there are 6 others that are multi-specialty centers that also have GI endoscopy. Other types of services like podiatry, of which we have like 7 ACs, orthopedic, which we have 12, and ENT, they provide those services as part of their multi-service offering in the multi-specialty ACs. Overall, of 54 ACs certified by CMS, only 17 have more than 1 service line. And of those, 7 have just 2 service lines that are usually very similar in similar categories, for example, like orthopedic and pain management. And only 10 ACs in Massachusetts, they are truly multi-specialty surgery centers that provide the full range of services. Next one. Next one. Yeah. This exhibit relies on EPCD claims data to show the volume and payment distribution of surgical services in ASCs in commercial population. You could see here that GI and endoscopy services represent the largest share of commercial encounters and payments. The share of volume is 64%, which is disproportionately higher than the share of payments, which is at 50%. Orthopedic surgeries such as joint replacement, repair of meniscus, or other sports injuries, or things like, again, joint replacements, are relatively expensive procedures, and they represent 20% of payments, while being only 8% of volume. Most of eye surgeries here are cataracts and glaucomas surgeries. And in commercial population, they account for 19%, although it's possible that for Medicare population, this proportion would be larger. And altogether, these three groups of surgeries account for about 90% of volume and payments in the commercial population. And the next most common group is neurologic or pain management services, which has 4% of the distribution. We also looked at this distribution of services for mass health population, and we found that the distribution is very similar, although GI services are a little bit smaller, while orthopedic and ENT services have a little bit higher share in mass health population. One note that we want to make about what this data shows us is that this is based on insurance claims. So here we don't have services that are typically paid out of pocket, such as cosmetic plastic surgery. So these services are not represented on these pie charts. Next one. This exhibit illustrates the share of services provided in ASCs versus HOPD setting by surgery category for both commercial and mass health patient population. Here, we limited surgeries in each service categories to those of comparable complexity, and we excluded procedures that ASCs typically do not provide. We also excluded a small number of procedures that are provided in office settings, because those are usually less complex and don't require anesthesia and less comparable to the collection of services provided, surgical services provided in ASCs. So these percentages show the percent of ASC and percent of HOPD out of total of ASC plus HOPD surgical services in a given category. This exhibit demonstrates that vast majority of ASC eligible services are performed in HOPD setting. For commercial population, only 22% are performed at ASCs, and for HOPD, and for mass health patients, it's only 8% of the ASC eligible services are provided at ASCs. Eye surgery is the only category where ASCs provide more surgeries than HOPD, but again, only for commercial population. For mass health population, this number is lower and stands at 30%. As we saw on the previous slide, GI endoscopy services are the most common type of procedures provided, but still it's only 27% of those procedures are performed at ASCs for commercial patients, and only 10% are performed for mass health patients. For most procedures, mass health has much smaller share of services at ASCs compared to commercial patients, with just a small exception of ENT services. Potential explanations for this discrepancy could be the referral patterns, location accessibility, and patient time or their ability to research the options for the surgeries. Next one. This exhibit provides the comparison of average price for the entire surgical encounter of a given type in AC versus HOPD for commercial population. We constructed surgical encounters to include payments for all services associated with the main procedure, which in addition to AC facility fees, include professional fees for surgery, anesthesia, and sometimes even lab or pathology services. The specific surgeries we selected here represent the whole spectrum of services that ASCs provide, and we try to pick at least one common procedure in each of the major surgical categories, including other surgical categories. For all of these procedures shown here, commercial prices are lower and much lower in AC relative to HOPDs, and the difference ranges from 55% lower for hernia repair surgery or 57% lower for myringotomy to 27% lower for epidural steroid injection, which is a procedure commonly used to manage back pain. The most common procedure performed in AC's colonoscopy is about 32% lower in terms of the total cost of the procedure when performed at AC relative to HOPD. Lower commercial prices typically result in lower patient cost sharing. For example, we found that cost sharing is 12% lower for colonoscopy, 13% lower for overall facility fees in ACs. It's about like half of the payments for surgical procedures there. The other half is payments that go to surgeons, anesthesiologists, or labs. There is another potential reason for the difference is that OPDs sometimes can charge for additional services that ACs are not able to provide due to their licensing requirements, such as, for example, recovery or observation room, or even facility fees for anesthesia, something that ACs don't charge. Next one. This conclusion slide just summarizes our findings, and we would like to emphasize once again that Massachusetts has among the fewest ACs per capita in the US, and the reason for that is probably historical regulatory barriers as well as current regulatory barriers, such as the requirement for new ACs to be in joint venture with a ACO in order to enter the market. We found that GI procedures, orthopedic procedures, and eye surgeries account for about 90% of commercial and mass health ASC volume. We also found that commercial prices for procedures performed in ASCs are typically 30 to 55% lower in ASCs than in HOPDs, and also typically result in lower commercial patient cost sharing. Mass health prices are also substantially lower in ASCs compared to HOPDs. HOPDs provide the vast majority of ASC eligible surgeries, except for eye surgeries in commercial patient population. ASCs also are less frequently used by mass health patients than commercial patients, and we need more research to understand and address the drivers of this difference. This concludes our presentation, and we welcome your questions.
Why don't we, Marty, and then Ron, thank you. That was fascinating. Thank you. Marty, let's start off with you.
Sure. Thanks, David. Great presentation. Do we know what's happening on the payer side, particularly around tiered networks, in terms of moving more towards ambulatory surgery centers?
It's a great question. It's a great question, and we don't have a lot of specific information on that. You know, we've heard from the ASC perspective that, you know, that can be an issue, or you know, and from their perspective, a barrier in sort of gaining patient volume. But we would need to look into that more, about sort of how wide, the extent of how widespread that issue is.
Ron?
Thank you. Again, excellent presentation. You know, it would be interesting when you look at the cost disparity, if you also measure, if we could, quality of care or results, and if they were basically equivalent, boy, that tells us something in terms of trying to move forward to make some changes to the regulations.
Thank you. You know, the literature that we found is, you know, is sort of based on, is national, you know, kind of based on national studies. So we haven't seen specific Massachusetts information, but you know, I think we would have no reason to believe that trends in Massachusetts are different than national studies.
Do we
And
know,
national size found.
do we know whether ASCs, some ASCs do or do not take mass health patients? Like, I wouldn't be surprised if some of them said no mass health here.
I think it's, you know, we had a very scientific approach of Googling, you know, a sort of very large sample of ASCs in Massachusetts, and sort of looking at their website for sort of seeing what payers they accept. And, you know, I think we haven't seen, I would say, you know, a lot of sort of obvious, you know, evidence of not accepting mass health, but it's, you know, I think it's certainly, you know, it's certainly an important possibility to be aware of, whether whether that's, you know, I think the sort of explicit not accepting mass health is probably a minority, if anywhere, but sort of some of the other potential drivers of the difference that we've listed, you know, sort of maybe more compelling. Did you have anything else, Katya, on it?
And it also depends on whether mass health managed care organizations, whether they sign the contract with specific ASCs. And when we talk to ASC Association, they mentioned that this is a factor, and that the ASCs that they know of, they accept mass health patients, that they don't specifically forbid them from, or forbid their surgeon from referring those patients. But it is possible that the absence of contract could be the issue.
Chair DeVoe?
Thank you. Just to add another thought to that thread of the discussion, I think looking at whether the same physician has equal utilization in referring their patients to a ambulatory facility versus hospital, you know, given the same service being needed, would be helpful to know. You know, in other words, is there a higher rate of referring commercial patients to, and Medicare patients to, an ASC than to a hospital-based facility?
That's an important point. Thank you.
Unfortunately, we only have indirect evidence of whether the patient was referred based on who was the primary physician, who could have potentially referred the patient to the surgeon. And then based on the surgeon, we can see where this patient was treated, either in COP D or at ASC. And many surgeons, they actually do it in both places. But we
Great.
would be able, we probably can see if the same surgeon, let's say, takes majority of his commercial patients in ASC and minority of mass health patients in ASC. That is something that is potentially possible to discover.
Chair Cutler, are we good to move on to our next?
Yeah, I think I was just going to suggest that. Thank you. Yes.
That's great. Well, thank you so much to Katya and Sarah for this incredible work and the discussion of commissioners. We're really trying to lead the effort in an inventory of this segment of the market, landscape analysis. If there are other landscapes inventories we could do, please let us know. We think it's important to gather history, gather information. These are important sites of care at a lower price point. So we're happy to talk about this more. All right, so we've got two federal regulatory updates from our market oversight team, another topic and another tied to our cost trends report recommendation. So I will now directly turn it over to the HBC's Director of Health System Planning and Performance, Kara Vidal, with an important update on automation of prior authorization. Thanks so much, Kara. Take it away.
Great. Thank you, Colleen. Hi, commissioners. Nice to speak with you this afternoon. We can go right to the next slide. Thank you so much. Okay, so as you may recall, in the 2023 cost trends report, the Commission included a recommendation related to reducing administrative complexity, which was to automate prior authorization. That was a recommendation that we developed in collaboration with NEHEN, NEHI, and MHDC. We've been doing some work with them over the last few years on prior authorization broadly. The first project we did with them was looking at potential reforms to the prior authorization process in Massachusetts broadly. And then after that initial project, we did a second project with them where we looked specifically at the benefits and potential of automating prior authorization. And the reason that we decided to narrow in on automation was in part because there was interest and support from the stakeholders in Massachusetts, both payers and providers, in exploring automation, but also because we knew there was federal activity in this area in the form of a proposed rule from CMS. And that rule is called Advancing Interoperability and Improving Prior Authorization Processes. And that proposed rule was released in December of 2022. It was actually a re-release of the rule that had initially been released in December of 2020. It was then withdrawn by CMS. There was additional thinking, changes behind the scenes, and then was re-released in 2022. And so we had been tracking the progress of that federal rule and had come to the recommendation that Massachusetts could really leverage some of this activity by expanding the requirements in the federal rule, which are specific to a set of public payers, to include commercial payers in Massachusetts. We also thought that there might be benefit in developing a roadmap that would guide a uniform implementation in Massachusetts, and that there could be the opportunity to establish supportive structures like a technical assistance committee or stakeholder engagement task force, financial assistance, et cetera. So that's the background here. And as Colleen said, CMS did finalize that rule last month in January, and they are estimating that this final rule could result in $15 billion of savings over 10 years. That's a big number, obviously very impactful. And so we wanted to let you know what is in the final rule and talk a little bit about what it means for Massachusetts. So we can go to the next slide, please. All right, so the federal rule has two primary sets of requirements. The first relate to prior authorization processes, and the second relate to the electronic exchange of health information. Both of these sets of requirements apply to the same set of payers. Those are listed on the left-hand side of the slide here. Those are Medicare Advantage organizations, Medicaid and CHIP fee-for-service programs, Medicaid managed care plans, and then not relevant for us, but also qualified health plans on federally facilitated exchanges, not our qualified health plans. For the prior authorization process provisions, the compliance date, mostly 2026. And then for the provisions related to electronic information exchange, the compliance date is 2027. Originally, it was 2026 for these health information exchange provisions, but in response to comments, CMS has extended that a year. So 2027 for that. And in addition, state Medicaid and CHIP fee-for-service programs will have the opportunity to seek a one-time 1-year extension to the compliance date. All right, so that's the who and the when, and now we can get into the what specifically they are required to do. So on this slide, on the right-hand side, you see the prior authorization policy process provisions, and there are 3 of them. The first relates to timeframes. So the rule will require that these impacted payers send determinations within 72 hours for an expedited request, or within 7 calendar days for a standard request, unless there are faster responses required by applicable state law, and then those would apply. The second is that when there is a denial, the payers must provide a reason for the denial. And then the third is that these payers will be expected to report a set of aggregated prior authorization measures on their websites. And we're expecting, I think, more guidance from CMS on exactly what those reporting requirements will look like a little bit closer to when the requirement takes place, which is 2026. We can go to the next slide, please. All right, and then here is the set of provisions related to health information exchange, which is where the automation of prior authorization piece lives. For your sake and for mine, we'll try not to get too much into the technical weeds here. And if you have questions, please ask me, and I may have to take them to our technical experts, but happy to answer what I can. Okay, so there are 4 individual provisions here related to information exchange, and the one that we've really been talking the most about is the one on the left here, this prior authorization API. And so at its most basic, the final rule requires these impacted payers to establish a FHIR API. And this is as technical as I'm going to get here. An API is a piece of software that connects computer programs. Think Travelocity or Kayak when you're trying to get multiple flights, or hotel listings from different airlines or different hotels. You get all of the data in one place. That's the API. And then FHIR is a specific standard for the electronic exchange of health information. Okay, so what does this FHIR API have to do? It has to allow providers to do 3 things electronically. That is, determine whether a prior authorization is required for a specific service. It must allow them to send the request for the prior authorization from within their EHR or their practice management system, and they have to be able to receive a decision from the payer electronically as well. And so that's really the automation piece we've been talking about here. And just to pause briefly on this first point here, we understand that there are many requests that are submitted for prior authorization that weren't required. Providers may be hedging their bets, making sure they're covered, submitting the request, even if it wasn't required by the plan. And so there's a hope that just even this first sub-bullet here is going to cut down on a lot of unnecessary administrative work here. The other 3 pieces here are related to prior authorization, but a little bit less directly. And this is about information that has to be able to be exchanged electronically with different parties, some specific to prior authorization and some more broad. So the patient access API, this is information that patients are able to see about their own about their own healthcare treatment and administrative data from the payers. So payers must now add prior authorization request and decision information into these patient access APIs. There's also provisions related to a provider access API. And so the idea here is that providers that have a treatment relationship with a patient would be able to get electronic information, including about prior authorizations from the patient's payer. There is an opt-out provision here. if the patient didn't want that information shared, but otherwise the payer would be able to request and receive certain information about patients from the payer. And then the third is a payer-to-payer API. And the idea here is that if a patient were to switch plans or to gain a second plan, sort of secondary coverage, supplemental coverage, what have you, at least 5 years of health information and data could be shared with the new plan from the previous or the concurrent plan through these APIs. All right, next slide, please. And then the final piece of the federal rule here is that it does include incentives for providers to use the prior authorization automation technology. And that comes through for clinicians, comes through the CMS Quality Payments Program. And for hospitals, it comes through the Medicare Promoting Interoperability Program. CMS is establishing a new measure that will be in effect in 2027 for both of these programs. It's called the Electronic Prior Authorization Measure. And under it, providers have to attest yes to ordering via prior authorization, electronic prior authorization via a prior authorization API, at least one medical item or service during calendar year 2027. Providers that don't attest yes can lose their meaningful user status, which impacts their Medicare payment level. So a pretty strong incentive for providers to participate. Shall I pause here, Commissioner Mastrogiovanni?
Oh, thank you. Quick question on the APIs. You've got a number of APIs, but they still need to build software at their end once they accept the API. Is that why it's being delayed, because of all the upfront work on the software that has to be done?
I think it's very much a technical, yes, a need for all of the technical implementation. Yep.
Okay, thank you.
Sure. All right, and then I only have one more slide, and this is sort of bringing us back to where we are in Massachusetts. So you have, again, the cost trends report recommendation that we had here. And I think we want to sort of reiterate our language here about the benefits of extending the requirements that are now final and will be in effect soon for these impacted payers to commercial payers, as well as developing a statewide roadmap that would inform all of this implementation and establishing some supportive structures as well. And I do think we believe that legislation is going to be required to accomplish these goals. You know, we've heard anecdotally that local payers are certainly aware of the final rule. They are taking steps to become in compliance on the public plan slide. We have not, I think, yet heard definitive commitment that the commercial side is going to follow suit unless they are required to do so, at least not on the same timeline. Maybe down the line, maybe if the benefits are strong on the public payer side, the commercial may come along eventually. But I don't think, certainly what our experts are hearing and those with the ear to the ground, is that everybody's saying, well, I'm definitely going to do this for all lines of business at one time. So legislation, I think, would be an important step if we want to see that sort of statewide participation. And I'll stop there.
Sorry, Kara, the private payers, are they not covered by in any of the categories that were regulated? They run MA plans, don't they? So you're saying it's only their MA plan that's required?
That's right. That's right. It would be line of business specific. And you're absolutely right. Almost all of our payers have either Medicare Advantage or a Medicaid MCO, but they wouldn't necessarily be required to do it for the commercial plans at the same time.
And are there additional costs once you're doing it for the MA plans or your Medicaid, probably MA plans? Are there additional costs to doing it commercial?
You're probably outside of really my area of expertise, and I imagine it's very dependent on the data systems of the individual payers. I think certainly in a market where payers have been joining systems over time. They're not necessarily all on one, data system internally. And so there it might be a real secondary cost. If one payer was using the same set of systems and processes for all of their lines of business, I would think it would be less so, but it's my sense that they're not always all on the same platforms.
I mean, certainly we should have some state legislation probably to require, but given the federal legislation, I wonder whether, we could check with the plans and say, look, are you planning on doing this for all your folks anyways? But we probably want some state regulation to make sure it happens, and potentially with respect to other aspects of harmonization.
Certainly the other aspects of harmonization piece would be nice. And, the informal outreach we've done is that payers are not saying, yes, I'm definitely going to do this for all lines of business, at least right out of the gate. Maybe eventually, but from what we've heard, people are thinking they're going to start with their public lines of business and may move to the commercial if they see the benefits, but, a little TBD on that front at this point. Commissioner Kwasnick.
Apologize if this is a dumb question, but those seem to be my favorite kinds. One thing that's on my mind around prior auth, which is maybe more of a automation and just automation in general, is have there been any studies on certain defaults that could get programmed into automation? I think one thing on my mind is around mental health parity and certain presets that could get baked into automation depending on what the algorithm is fed. Just curious if that's been part of the conversation. I know it's a little bit off topic here, but of a piece. So just want to keep it top of mind.
No, that's a really good question. And my answer is really tangential and maybe about the opportunity that exists here more so than the risk. But what we've heard is that the biggest piece of work, and take this with a grain of salt, I'm not the technology expert here, but what we've heard is that one of the biggest pieces of work in this implementation is going to be the digitization of all the rules that the payers use to determine whether or not to approve a prior authorization. They're very complex. They can have multiple branching pathways for a single authorization type. And of course, there are many authorization types. And now they're going to have to turn them into algorithms that will allow sort of the systems to process the data in accordance with them. I think there's an incredible opportunity here to not do this payer by payer. I mean, obviously we can't, that's not part of the rule. That's just an opportunity that exists. But to your concern, and I understand exactly what you mean with your concern, there would be such a nice opportunity to try and identify those areas where you can be baking in, the wrong clinical decision into the pathway. And there could be an opportunity to try and recognize that and address that across payers if this rule digitization process was sort of done in harmony.
Yeah, because I think one space is just, I guess, within a state role I can see here is making sure that whichever regulating body is charged with reviewing it has the right expertise and, has been adequately trained to recognize and to read the algorithms instead of just trusting the process, because we all have blind spots. And there's a lot of reasons why we have blind spots, and it's always good to have an iterative process on these sorts of things.
Yes, and I will say, I don't think that absent legislation and absent a desire from the state to have greater oversight, that there will be any requirement that these algorithms be reviewed by an outside party. So another potential reason to think about trying to do this in a collective, overseen manner at the state level.
Yeah, don't want to pretend I have a position on whether or not legislation should be filed. I don't want to speak for anybody on that, but just want to note that that's the role of the regulator here is really integral.
Thank you.
Thank you.
Chair Cutler, I'm so sorry to do this, but looking at the time, if it's okay with you, and please don't question my time management, would it be okay if we dispense with the last agenda item? We do have a full staff memo on the merger guidelines update that we will send to all commissioners. So if it's okay, we'd like to conclude with the MOAT committee and move on to our special presentation from Karen Tseng.
That sounds great.
Okay, thank you so much. Okay, without further ado, thank you to our Market Oversight and Transparency Committee members. We are moving to a special interim presentation that spans both committees. And as I said in the beginning of the MOAT committee, I welcome other members, the MOAT committee members, the CDT committee members, and our chair, Deb DeVoe, to the special presentation. As by way of introduction, part of the Haley Driscoll administration's ongoing commitment to regional and racial equity, they have laid out incredible plans for advancing health equity in Massachusetts. Their critical work has deeply engaged state agencies, including the HBC, including stakeholders from across the state. They're talking about reworking systems that lead to poor outcomes for vulnerable communities. So grateful for Karen Tseng for joining us today. Karen, as you all know, is the Senior Advisor of Health Policy for the Executive Office of Health and Human Services and is also official HBC Board Designee for Secretary Kate Walsh. So grateful, Karen, for you joining us today. We're so excited to hear about the administration's commitment to health equity. Thank you.
Thank you, Colleen, so much. And thank you to the commissioners, to Executive Director Self, and the entire HPC team for your partnership on this. You know, Colleen, as you alluded to, there's a lot of pre-work that goes into even getting to where we are today in terms of this strong, clear-eyed vision. We're really looking forward to delving more into the specifics of this strategy with you all today. And I also wanted to thank our common partner, our common thought partner in this, the Health Equity Compact, for their critical leadership in this space. And to the many, many organizations in Massachusetts and in our communities who are doing the challenging frontline work of improving health outcomes day in, day out for the populations that need it the most. Thank you. I know I speak for all of us when we say that to us, your work is truly inspirational. So if we go to the next slide, what we hope to cover today and have a good discussion around is first to touch a little bit on some data and evidence. Second, to also share in greater detail that strategy and approach. And then to round out with a dialogue around next steps and how each of you may have input on how we can improve our collective efforts together. Next slide, please. So if we thumb through, I know folks have copies of these slides. If we thumb through this slide, and if we advance to the next one, and then to the third. And then we can go back to the first of these three in the series. But I think what we can all agree is that the consistent shape of these graphs, the fact that, as Undersecretary Mahania would say, outcomes are stratified with shocking correlation between how dark your skin tone is, that's such a reliable predictor of poor outcomes, that's the definition of egregiousness and injustice in our society. And so we have all seen, unfortunately, many versions of slides like this that look at different conditions and that really hone in on outcomes by race, by ethnicity, whether it's severe maternal morbidity, whether it's infant mortality, whether it's cardiometabolic outcomes, SUD outcomes, many others. So I know I'm speaking to an expert audience in saying that in this country, zip code is more predictive of those outcomes than our own genetic code. And so I think the first North Star to share in terms of our proposed approach is to have the courage of pinning our North Star to these outcomes. So it's a priority for this administration to continue tracking outcome measures in complement to the other very important measures out there, including patient engagement and satisfaction, process and access measures, but to really hang our North Star on outcomes such as these and hold ourselves to seeing improvement in these outcomes as the indicator of whether we're making genuine progress, even where we know that a realistic time frame to see movement on these metrics is in the years, not in the months. And so having the commitment and the will to continue to make that the definition of success is really the first and most important North Star that we wanted to share. The other thing I'll just note, again, many data experts here across the commission. So we'll just mention that the slope of this particular slide does seem to be climbing, and that is not the direction we want it to be headed in. If we go to the next slide, we see that same shape of outcomes being stratified and differentiated by skin tone. At least with this graph, we do see that there is a modest decline in the slope over time. That's another part of the shape to point out. And then if we go to the final data slide in this series, this is one that tracks cardiometabolic outcomes. I believe the underlying data is cardiovascular disease coupled with diabetes outcomes. If we go to the next slide, some of the touchstones I mentioned, having our strategy be outcomes anchored. Also, place-based, condition-focused, and community-led. What do those words really mean? I alluded to a serious health equity strategy, recognizing the intersection between place and outcomes, between geography and equity, and that in our country, zip codes have become more statistically predictive of what your outcomes are than your own biology. So if we want to get serious fast, complementing statewide approaches, which are incredibly important, with more precision and more focused place-based investments is a really needed complement to that kind of a serious strategy. When I say condition specific and condition focused, it's recognizing that rather than collapse under its own weight, it's important to start in an initial couple of focus areas to make sure that the approaches that we're taking, the ideas that we're collaborating on, that we're seeing some signals in the data that we're making progress, and that we can build on that progress and what works to expand and to amplify. And in terms of being community-led, I think you can see a lot of that described throughout this slide, the importance of working closely with the communities we seek to serve, to understand among a wide range of issue areas needing our attention, what's most important to individual communities, to localities where you think about the infrastructure in a community in Western Massachusetts versus Eastern Massachusetts in terms of transportation is going to look different. When you think about leading health issues in different regions in the state being different, when you think about the composition of different populations of different demographics, leading to a level of distinctions across different regions that are so important to understand and really to create space for communities to be able to lead with their own voices in terms of what's most pressing to their communities. Next slide, please. So on the two very high disparity conditions that we're proposing to start with, to continue to, again, examine how well we're doing, to pilot some of these place-based investments, and to really look very closely and hold ourselves up to those metrics in terms of tracking progress to see what is working and what should be amplified. So you see both of those, what we're calling subject matter area work groups shown on this slide. Our initial policy areas of focus in maternal perinatal health and in cardiometabolic disease. On cardiometabolic health, what our secretary would say is that the healthcare system overall, the medical system and government alike, tend to be really good at the downstream to respond later on when the disease has developed, when there are clear harms that need redress. And the importance of embedding social determinants of health and the frame of social drivers of these poor outcomes in the name of the cardiometabolic work group itself, it's really an effort to signal that we're not going to be successful if we aren't doing what we know the HPC and so many others have championed, which is getting upstream, getting into the preventative, getting into the structural drivers of these poor outcomes. And we can and we should really think of social drivers as embedded in both of these work groups fundamentally, and that by calling it out and naming it, that it can continue to tug us further upstream and to get us, when Colleen describes systems change and how EOHHS as a secretariat is organized and how our levers over time, over decades, have become accustomed to operating, how we respond to emergencies, how we organize ourselves against the work. Our secretary would say there is clearly room for thinking outside of the box and for system evolution so that we're organizing ourselves more clearly to be proactive in upstream spaces and in structural spaces around those structural drivers. So those are some of the thoughts that I would share specifically around those two initial areas of policy focus, and some of the goal and the mandate to be very focused upstream. What you see on the bottom of the slide is two incredibly critical function areas. If maternal perinatal and social drivers of cardiometabolic are subject matter areas of focus, then being community-led and being data-driven and evidence-anchored are really our functional work groups. And these two functional work groups, the HPC is absolutely embedded in this work as members of these teams in really leading with best practices on the data front in terms of assessing where the gaps are in these two issue areas, honing in both from this perspective of interventions, things that are working that we need to amplify, and also honing in on what the data say about the particular neighborhoods and communities across our Commonwealth that most need our help and support and attention. So both using data in that diagnostic phase and also in the design, implementation, and of course, assessment and monitoring, ensuring that how we adapt particular interventions for different populations and communities and how we work with communities to develop and co-design what makes sense is truly data-informed and data-led. And then also ensuring that on day one, we are putting in place dashboards with a set of more proximate and distal measures with a good balance between measures of consumer and client satisfaction, of process and access, and also of outcomes, and being ready on day one to have a mirror that we're holding ourselves up against and seeing what works and what doesn't. Next slide, please. Many of you are familiar with a report that the administration issued a couple of months ago that was really synthesizing and serving as a culminating vehicle for more than a decade of community engagement, community response, and expert partner-led statewide bodies, including the Maternal Health Task Force. That entire series of incredibly important work and findings that have really led to a clear set of recommendations and priorities to shift from describing the problem to really addressing the problem. This slide captures those top statewide recommendations drawn from those voices, all of those voices, over the last several years, and really hones and integrates it completely into this initiative that we're describing, where a measure of progress, a very clear, tactical, and concrete measure of progress for the maternal perinatal health equity work group is if we make achievable month by month, quarter by quarter, year by year progress on these recommendations. If being outcomes anchored is one of our North Stars, then making tactical progress on each of these concrete action items is what you can think of as, the day-to-day metric that we're holding ourselves against. You'll see running through this a theme of bringing a lens of racial equity to this work, leading in that way explicitly, and of course not exclusively. Next slide, please. In rounding out some of the other guiding principles to this work, in addition to the focus on maternal perinatal and on social drivers of cardiometabolic outcomes, with an emphasis on being evidence-led and community-led. This slide, I think, hopefully does a good job in explaining another one of those core guiding principles, which is being place-based. So a lot of the important pre-work was taking every available database that we have in the Commonwealth that looks at a broad range of health outcomes. Cardiovascular disease, diabetes, stroke, SUD mortality and morbidity, maternal health, infant health, opioid outcomes, environmental justice, and really descriptively honing in a consistent way. And this work has been shared with others that have been looking at the exact same data to confirm methodology and alignment. To really be able to state if we are being honest and descriptive about how sticky outcomes are in America, and overlaying the truth that zip code is more predictive of your outcomes than your own genetic code, then from a purely factual perspective, which are the communities where those outcomes are consistently, when you think about disparities, when you think about a waterfall, on the wrong side of that graph, right? And what that analysis affirmed, revealed, and confirmed is that across a whole range of outcomes, the patterns are very sticky in our state, and that there are a set of communities that if you look at it, whether it's from the CDC Social Vulnerability Index or any of the metrics that I just described, are areas where disparities are most profound. And so that's the factual list that you see described here, organized into, a set of regions for ease of reference. And if we go to the next slide, you'll see each of those regions, described. And we're open to feedback and improvements in describing and naming. Sorry, if we go to the next slide. So you see that written on the left, and you see the specific zip codes or the specific towns displayed as well. So I hope that the right side of this slide ends up being, a great catalyst for the dialogue that we have today, among many topics that I hope we get a chance to discuss today. And that's taking a very community-led and community-centric approach to how we think about maternal perinatal health and how we think about cardiometabolic outcomes. I said earlier, there are things that need to be done statewide. Grab any maternal health expert and they will let you know that we need to do more to foster a whole spectrum of levels of care in our state, and to send clear signals, have clear supports around that, to foster and support midwifery models of care, to amplify and support spaces in the care continuum that have been traditionally under-resourced and overlooked, like the importance of doula care. And so the types of changes that support that are absolutely statewide, like Mass Health really being an innovator in leading with a statewide doula benefit for all members. That statewide work should be complemented by very place-based collaboration, coordination, alignment, and investment in a way that I mentioned earlier is truly led by community voices around those aspects of maternal health that are most critical to that community. The barriers to better cardiometabolic outcomes that individual communities may have that are unique to that community. I mentioned transportation as an example where some key barriers in certain parts of the state may not be the exact same challenges that other parts of the state are facing. And so the circle that you see on the right side of this slide it's a visual, it's a vision, it's an ideal of having that type of local community forum, a regionally based community table around which key organizations and key voices around that community reliably come on a recurring standing basis to lift up that set of priorities for that community and to work in an aligned fashion with the public sector, with the private sector, with the many organizations that are leaning into this work, are seeking to lean into this work, are seeking to resource this work. And instead of, funding a one-off grant, really thinking about how to align those resources towards common goals and system change. And there are so many communities around the state that have formed these types of regional forums and these community tables that EOHHS is not looking to recreate and not looking to re-silo and not looking to rewrite, but to have the humility to discover and understand where those authentic spaces, where that work is happening, and to ask to be invited to that table with the set of resources and alignment and tools that we can bring to be part of a broader, more aligned, more systemic conversation. And certainly using the role of government to foster and encourage that kind of alignment. And I know that there have been and continue to be great conversations with local boards of health, we have a healthcare anchor collaborative in this state. We have Atrius Health Equity Foundation working assiduously in Eastern Massachusetts. The Blue Cross Foundation that just had a launch event in December and is looking statewide. Many, many, many organizations, big and small, looking for ways to align, coordinate for these common purposes. And if you can imagine many of these tables multiplying across our communities, and EOHHS and the administration looking to tap in, to dock in, and to integrate into that work, I think that is an accurate way to describe, our vision and our goals and our hopes here. Next slide, please. So this is the last slide in the deck. Would love to really prioritize discussion and dialogue and feedback for the balance of our time. So I'll turn it back to Chair Cutler or the chair of this committee or Colleen.
Sure, all those work. Thank you so much for that incredible presentation and the work you all are doing, Karen. What do we have for questions for our colleague?
If I may, it looks like my hand isn't raised, but I thought I did. May I, Karen, if I may, this was wonderful. It touches me to hear all of this, and I guess also to let you know that we've been trying to do that in Worcester, and I think part of our issues is trying to get data. And I know you talked about the importance of data, and for us sometimes we have to depend on state data, which falls behind what local data is. We've been trying to get all our local entities to provide their data from EMRs, so we know what exactly it looks like in Worcester. Not only, I think globally we know what the inequities are, but we want to show it, and we want to show it also where it's located. We would love assistance in that. I think we have hospital and a health center, and we're getting more in line with the rest of the health entities in Worcester. But I think when we tried to do, for example, looking at GI and everybody was willing to do this. Everybody talks about then funding to be able to do this. How are we going to, we know what this inequity is. We need to go out into the community. We don't have the funding and the ability to have that kind of a team to go out into the community. How will we be able to do something like that? We did it when we did it with COVID, and we know how to do it. And we had the data available because we have control of that data. But with everything else, we don't have it. And the graphs that you show, we know that. How do we go out into the community and be able to bring the resources into the community? I think for us are important, and I look forward to working with you to figure that piece out. So thank you.
Absolutely, Commissioner Castillo, and appreciate your really highlighting that from a local regional perspective, and how I'm sure many of your counterparts in other regions of the state would echo some of those foundational barriers. So I'm looking forward to following up with you offline, both on a couple ideas off the top of my head include connecting you with the leads of our emerging data work group, and really thinking about the public health data warehouse and some statewide resources and how those could be levered for those much more local and regional kinds of insights, that business intelligence. And also, I know Commissioner Goldstein has been in touch, and now is the right time to sit down together and have a very tactical conversation with your leadership and vision for what this practically looks like in the Worcester area. So I look forward to that.
Thank you. Likewise.
Commissioner Houch, do you want to go next?
Yes, just I know we didn't go through it in detail, but I thought the maternal recommendations were outstanding and really well thought through. One thing I didn't see on there was prenatal nutrition, which you were talking about preventive areas. I just think that one kind of jumped off the page to me about adequate nutrition. And the second is completely different, and that is in your communities that don't have these alliances or coalitions that have been built at this point in time. What do you do to initiate that? if there's an area that is completely underserved, say in a remote area of the Berkshires, how does your office or how does that process then begin?
Great question. So just taking a few notes here and heard loud and clear on prenatal nutrition. And thank you for that feedback. So I could not agree with you more that an area of disparity is a disparity in infrastructure and in fundamental resources to create that space on an ongoing basis where communities are able to get organized in that way towards those common purposes. So something we're looking very closely at and work is actively underway, I can attest to, is having those conversations with different organizations and groups that understand the importance of resourcing and funding standing public health infrastructures and convening infrastructures as a key ingredient if we want to meaningfully and sustainably
make a change.
Make the change. And so that is a foundational level of conversation that is happening right now with some amazing groups stepping up to say, we will, signals appear to be, we will fund that. We will make in those areas where that infrastructure doesn't really exist, a priority, and look forward to being able to share more as those conversations become more ripe. And also, I would say the corollary to that is, again, not having the hubris of where it's already working well and folks have, created that, kind of stomping in and saying, oh, we need to like redo. No. This is about going to where there are the deficits.
Yes. Wonderful. Thank you. Commissioner Blakeney, I thought I saw your hand up.
Yes, thank you. You did. I think my question was mostly answered. But Karen, first of all, thank you for a devastatingly clear picture. When you first began the presentation, I did feel, in fact, devastated by the data, and then started to ask myself why. Because we've seen data like this over and over again, packaged differently. I think what you've given us is a blueprint in terms of location and targeted populations that we need to be laser focused on. And I think if we use that and also focus hard on outcomes, the outcome has to matter above everything else. How we get to that outcome, how we structure it, how we provide resources, how we provide funds, how we provide expertise is all open to discussion and negotiation. And as a old-time community organizer, I applaud strongly the engagement of community and the work. Don Berwick has always taught us nothing about me without me. And that applies to community. I use that expression all the time, and it's critical. So I encourage those aspects and those that framework, and look forward to being able to partner with you in any way that is possible to help bring this forward. So thank you for the work, thank you for the effort, and thank you for the clarity.
Thank you, Commissioner.
Dr. McGregor, I see your hand up.
Hi there. Good afternoon. Apologies for the camera off. There's a little something going on here today, some construction. But just wanted to thank you, Karen, for the wonderful presentation. I echo my colleagues in terms of the clear urgency of what you've presented, and also the tremendous importance of targeting the communities that need it most. I dropped in the chat just a quick suggestion just with respect to the Boston area communities. I can't necessarily speak to the other regions of focus as well, but I would suggest that among the Boston area communities, you have their Roxbury, Dorchester, and Mattapan, which, clearly we've known these neighborhoods to be neighborhoods with the greatest needs for, as long as I've lived in Boston, and certainly longer than that. But I also believe that Hyde Park should be among these neighborhoods. And I don't just say that because I live in Hyde Park, but a recent report by the Boston Public Health Commission, sorry about that. There is construction going on. So a recent report by the Boston Public Health Commission did find that Hyde Park had the highest infant mortality rates among any Boston neighborhood, which is really, really telling. And with the focus on maternal health, perinatal health, that's extremely important. And also just really quickly, I want to just applaud you for your focus on the upstream factors, structural factors, and also the Healy-Driscoll report that emphasizes the importance of pay parity among midwives and physicians. So looking forward to talking more at length about this, but those are just my few comments for now.
Really appreciate it. Thank you, Dr. McGregor. It's very timely. We have our regular huddle with Commissioner Ojikutu. I think it's tomorrow morning. And so thank you for the data insights.
Of course.
Any other questions for Karen? Okay, well, I want to thank Karen so much on behalf of the Health Policy Commission and our committees. Thank you so much. On the HPC side, we are supporting this effort on data coordination. We're part of several data work groups, and so we're happy to support this group in any way moving forward. Chair Blakeney, I would suggest that we take a brief break and gavel back in and reconvene at 2 p.m. for the start of your committee. How say you?
I like that thinking. Let's do that.
Let's do that. We'll take down the live stream and we will reconvene at 2 p.m. Thank you all so much.
Thank you, everybody. Okay.
Okay, we're good. We're live.
All right. Well, thank you, everybody, for joining us again. Those of you who have been with us since noontime, I once again congratulate you all on your stamina in sticking with us. This is the CDT meeting, and we're going to be discussing two items. I know I have to do the minutes, but we're going to be looking at two major areas of focus, which is maternal blood pressure monitoring, and then our LEAP program. And given the conversation that we had just a few minutes ago, both of these programs are critical to the work going forward. So let me begin by asking for a review of the minutes. Are there any additions, comments, or corrections to the minutes? Hearing none, then shall we go through the list, Colleen?
I am happy to do that. Do we have a motion to vote?
So moved.
And a second?
Second.
Great. I will start with you, Chair Blakeney.
Yes, approved.
Okay, Commissioner Cohen?
Approved.
And I think Dr. Castiel, are you able to vote?
I don't know if I was at.
You were at the last meeting. I just didn't know.
Okay.
If you
Then yes for me. Okay.
Appreciate you. And Commissioner Tseng.
Yes.
Thank you. Back to you, Madam Chair.
Okay, thank you. I'm going to fairly quickly turn this meeting over to Kelly to begin our discussion and our review of a new potential investment program regarding maternal high blood pressure and monitoring that. So all over to you, Kelly.
Thank you so much, Commissioner Blakeney. I feel very, very lucky today because I have been teed up really nicely first by Karen's presentation and by your introduction. So why don't we get straight to the content? Next slide, please. So just to ground everybody, first of all, about what the purpose of this conversation is today. My goal is to provide a very brief overview of the context for our exploring an investment in remote blood pressure monitoring, a brief orientation to what remote monitoring is, where we are in the process, and what comes next. This presentation is going to be quite brief because we're still very much in a work in progress stage, but I hope and expect that we'll be able to come back to you later in the spring or early summer with a more comprehensive update. So let's dig into the content. So this slide really, I think, tells a very similar story, maybe with slightly different visuals to what Karen shared earlier. And really underlying this opportunity are the very stark and alarming trends in severe maternal morbidity that we heard about earlier today. As I said, this is simply another view of the same story Karen told of an upward trend in severe maternal morbidity with significant disparities among Black, Hispanic, Asian and Pacific Island birthing people as compared to their white population counterparts, reflecting inequities in care, access, social and economic factors, and the enduring effects of racism. And so, as you heard, state agencies are mobilizing to address this challenge through Advancing Health Equity Massachusetts, which I'm going to call AHEM going forward. I don't know if that's the approved nickname, but I'm going to go with it for now. Next slide, please. So obviously, part of the work of AHEM and other groups is to understand what's driving the outcomes in severe maternal morbidity. And as noted in the DPH review of maternal health services issued this past November, one important contributor is hypertensive disorders of pregnancy, which is a leading cause of severe maternal morbidity and postpartum readmissions. This is a significant enough factor that the same DPH review included adoption of remote monitoring as one of 25 actionable recommendations to improve maternal health. And as you saw on Karen's slides, that recommendation has carried through as a priority for AHEM's maternal health working group, with an emphasis on both adoption of remote monitoring and telehealth and coverage for those services. Next slide, please. So before we go too much farther, it's easy to talk about remote monitoring and what it is. And my hunch is we all have a kind of a sense of what I'm talking about. But just to be sure, let me provide a very, very simple view of how this all works and a little bit of background about how we got here. So remote monitoring, which is often bundled with telehealth, is certainly not a new concept. But like a lot of things, the COVID pandemic motivated greater interest in and experimentation with approaches that reduced the need for in-person visits. Kind of at the same time, increased efforts to address maternal health inequities highlighted the need for more effective strategies to manage hypertensive disorders of pregnancy, including through the postpartum period. Kind of at the intersection of these two forces has been a lot of experimentation that has generated a fair amount of literature about the feasibility and efficacy of remote monitoring as a strategy to address these disorders. So when we talk about remote monitoring, and let me emphasize, this is the kindergarten version of what this can be. We're really talking about a process that starts at the top with data collection. Patients are equipped with technology that allows them to record their blood pressures and seamlessly transmit those readings, sometimes using a mobile phone, sometimes through cellular connections. From there, those data are received at a central point and triaged for appropriate follow-up. What that central point looks like can be quite variable. In some cases, it might be a care manager receiving those data, but it could also be a third-party vendor. Those data could also be pulled into an EHR and be integrated into a workflow. So there's a lot of variability, as I said, but fundamentally, the idea is that the data are received and then prioritized for action. And again, what that action can look like can be really different depending on the nature of the implementation, the focus of the program, just in general, features of program design. So for example, If a patient were to report a normal blood pressure value, it could be a text message follow-up saying essentially, keep up the good work. If a value was reported that was concerning, the next step might be a telehealth visit, or it could be a medication consultation. In theory, it could be a recommendation to visit the emergency department if the reading were of concern. A lot of things can happen in that follow-up, but the point is to create this virtuous cycle of data collection, transmission, action, and follow-up with the goal of avoiding negative outcomes, including readmissions. Next slide, please. So why is remote monitoring an option that people are talking about that's worth considering? So I think obviously the most important thing is that it offers the potential for a reliable, patient-centered approach to managing a disorder and it provides the opportunity to do that management outside the setting of an office visit. So there are some particular advantages to both patients and providers that this particular modality does offer. I think the first on the patient side is it does create, and I would say the aspiration is to allow patients, or to create, I shouldn't even say allow, but to create a context in which patients are trusted and empowered to be partners in managing their care. And part of making that feasible to do is by integrating technology that reduces burden on patients by bringing care to them. And that is certainly, especially important for people who have challenges with access to transportation or childcare. Finally, it creates a valuable bidirectional interface between patients and providers. And I think one of the really interesting things we've heard in some of our early stakeholder engagement around this concept is that once that sort of connection has been made, it also presents the opportunity to learn a lot more. So, for example, even if I'm in conversation with a care manager about managing my blood pressure, perhaps as part of that conversation, I share some information about, feelings of depression, or I share information about lack of access to services. It's really about, as I said, once that connection's been made, there's a lot of opportunity to learn more and ideally to intervene in support of patients. For providers, this is fundamentally about targeted, scalable care management that does not rely on a visit to the physician's office or the hospital. Because of the technology, there is an opportunity to enable team-based care and take some of the responsibility for managing hypertensive disorders off of the clinician's plate and distribute it more evenly across different kinds of functions. It really, hopefully, there's a fair amount of literature about the opportunity to avoid costly, avoidable readmissions, fundamentally by trying to get ahead of problems before they become serious enough to warrant a readmission. And of course, I think, again, the sort of complement to the value of a reliable bidirectional interface for patients is for providers creating a positive experience with those patients that ideally helps them forge more durable relationships. Next slide, please. So why an HPC investment in remote monitoring? Let me talk a little bit about where we are today. I think our foundational hypothesis right now is that the rationale for an investment is strong. And there are several reasons for that. First is obviously the significant alignment with EHS priorities and an opportunity to contribute to the cross-agency efforts that Karen described. I think she mentioned earlier the goal of making tactical progress. And I think this is an opportunity where we could contribute to that tactical progress in this area. There's also significant alignment with HPC priorities in care delivery innovations and in our focus strategically on health equity and cost. We also have the opportunity to build on some past experience in both maternal health investments and telehealth. As I've mentioned all along, there is a decent evidence base for feasibility and value, and that's both in the literature, but also we're very fortunate to have some on-the-ground experience. The Perinatal Neonatal Quality Improvement Network, or PNQIN, has been running 2 pilots that we've had the opportunity to learn a bit about. And Boston Medical Center has had a program in place for quite some time. So we have been able to talk to those organizations, understand a bit about how they've implemented, and also hear about the impact on patients and providers. And finally, and I think this is an important one, it fits well into an investment framework. There are, I think, a lot of things, if we were to look at the healthcare delivery system, that we might want to influence or change. Not every one of those things is amenable to investment. And I think our preliminary hypothesis right now is that this one is, because we do think that there could be an opportunity to accelerate the broad adoption that AHEM and EHS has prioritized through some investment of what I guess would euphemistically call startup funds. And there is a path to sustainability, which I know is a priority for this group, both in terms of probably through a combination of return on investment through avoided expenses, and also with the hope that there will be a path to funding as well, or to payment as well through payers. So that is the hypothesis for now in terms of both the rationale and the opportunity. We can go to the next slide. Let me tell you where we are. So as with any investment program, the devil is in the details. And we are really at a phase right now where the work is to figure out the details and make a final decision about doing this work. Part of that will obviously be, or I hope obviously be, continued stakeholder engagement, not only with providers and payers, but also from the population, as close as we can get to the populations that we would hope to serve through a future program. Then there is the work of really thinking through the nuts and bolts of the elements and scope of a potential investment. Who's eligible, duration of services, expectations, technical assistance, obviously the total funding. So that is, the nitty-gritty work of sort of sorting this out. Finally, and or not finally, but second to last, I guess, we also have an opportunity here to really apply lessons learned about integrating equity into both how we do this work, how we suss out the program, and then ideally how we execute it. I know we have come to this group on a number of occasions to talk about work that the Healthcare Transformation and Innovation team and other parts of the agency have undertaken to embed health equity. This is kind of an opportunity for us to put that learning and that experience to use. So as we do this exploration, we will not be doing it alone. Obviously, we will stay very close to the work of AHEM and the Perinatal Maternal Health Work Group. We'll stay closely connected to our colleagues at Mass Health. And also we'll be working closely with PNQIN. And I really do want to call out right now Kristen Price, who is the Administrative Director of PNQIN, who was from the moment that this was a tiny kernel of an idea, has been working side by side with us to understand how we might make this work, what these programs look like, and what they have learned from their own experience. So, as I said, this is a truly an introductory, here's where we are, here's what we're learning presentation. So there's not a whole lot more detail to provide you, but I am more than happy to answer questions.
Are there questions?
Kelly, I have a question.
Sure.
This is not new technology. Remote monitoring of blood pressure has been around for a long time.
Yeah.
Do we know what the barriers to adoption are?
I think there, I mean, I will give you a preliminary sense, and I know, obviously others have been deep in this space and should chime in as well. I think there are a few things. I think remote monitoring of blood pressure has been around for a while. One of the things that I think is slightly more innovative is this kind of seamless transmission of data to try to just make it easier for people to do. So as opposed to I take my blood pressure, I log it into a website, it gets sent someplace. In some cases, these data are being uploaded directly. So just trying to make it easier. I think the other barrier, as we have heard, and I just want to qualify this by saying, we're still out there hearing, listening, learning, is payment and how providers are reimbursed for this work. When you look at the totality of the circle, it brings together a lot of different pieces, some of which are reimbursed, some of which are not. So I think it's trying to figure out what that total package looks like, and also potentially to recognize that there are some startup costs that would otherwise, represent expenses to providers that they wouldn't necessarily see a path to being compensated for.
Thanks.
Maddie?
I think I always worry about the preventative pieces and are they being paid for? Because obviously if there's a diagnosis, then much easier to get paid for, but to say preventative, is that what we're going to pay for? And I guess my other question is, or my other thought or question is anybody doing it now? Is there an entity that's doing it, and what has their outcomes been in decreasing maternal mortality in that sense with the data? Has that improved?
There are organizations that are doing this now. I am not aware of the data on maternal morbidity or mortality writ large. I think that we could certainly look to outcomes and results from those individual pilots. I just don't have the information to tell you whether those individual outcomes within the pilots then translated to a measurable decrease in maternal morbidity. I just don't have the data. I wouldn't say no. I'm being honest. I don't know.
No, and I would love to know that. And if there's minimal, or what are some of the things that they're noticing? What are the gaps, if any, with that? So I appreciate that.
Kelly, could you clear the screens, please, so we can see all of our commissioners?
Can I clear the? Oh, yep. There we go.
Okay. Thank you. I just want to be sure I wasn't missing any hands. Kelly, I have a question for you, and that has to do with selection criteria. Given Karen's presentation and the map that she showed us, is there early thinking about specifically attempting to focus on those areas? I believe Karen identified 10 geographic areas. Are we looking at that?
It's a great question, and I think absolutely we will look at that. I think the other thing that the two factors that will play into eligibility will be the source of funds and any rules that exist around how we can use funds. And as some of you know, we have trust funds that often support investments, and they have rules. And I think unquestionably we would include as a selection factor the priority geographies that AHEM has laid out.
Okay, thank you, Kelly. When do you think your work will be done for a formal presentation and approval? I'm not anxious or anything.
Not me either. And if you looked at the slide deck I made for a meeting last week, I made an ambitious timeline that's so ambitious that everybody laughed at me. So let me say we are moving, as quickly as we reasonably can while doing responsible due diligence. I mean, I think the worst thing we would want to do is go so fast that we make a mistake that has unintended consequences that make this program less than it could be. But if I would like to be in a position to have the details sorted and be prepared to move on an investment, unless we hear something in the process that suggests that this is not a good idea, in late-ish spring, that would be great. But as I said, a lot can happen. Up, David Selt has his thumbs up. Okay, excellent. Later spring would be the goal. And we can define spring as we choose to do it. I'm thinking, ideally.
Well, if David's got his thumbs up, that's pretty good. Okay, any other questions for Kelly before we move on? Kelly, thank you so much. Look forward to seeing the more formal and completed presentation with the data points and the outcome measures. So thank you.
Great.
Let's move on to our lead program.
Excellent. Maybe I can provide a little bit of a lead in. So as we just heard, one of our really valuable levers that we can pull to achieve healthcare transformation and innovation is our investment lever. The other big lever we have in this particular space is our ACO certification program. So for our second agenda item, my colleague Mike Stanek is going to share the results of the latest LEAP certification and provide some highlights of what we learned in the latest cycle, including what we've learned from our kind of first significant attempt to embed health equity requirements. So with that, let me hand it over to Mike.
Great. Thank you very much, Kelly. And good afternoon, commissioners. I am very happy to be here today to provide an update on the Accountable Care Organization certification program. We spent much of the fourth quarter of last year reviewing applications for certification, and I'm very pleased to be able to announce today that all 14 ACOs that applied for recertification have met our criteria. So each of these ACOs you see here was previously certified by the HPC at the end of 2021. This marks the fourth cycle of ACO certifications since the program launched in 2017. These two-year certifications will be effective until the end of calendar year 2025. As a reminder, the current total number of HPC certified ACOs is actually 17. In addition to the 14 ACOs that we are recertifying, 3 additional certified ACOs are eligible for recertification later this year. And those are Berkshire Health Systems, East Boston Neighborhood Health Center, and UMass Memorial Health. As always, we want to congratulate and thank all of these organizations for their partnership, and most importantly, for the dedication that they've all shown to providing high quality, efficient healthcare for their patients, ACO structures and operations. To that end, today I want to speak to what we saw in the ACO applications last year, including the kinds of activities that ACOs are undertaking in some of the key areas that we examined via certification. And I want to start by sharing just a few high-level takeaways. As we'll review in a few minutes, when we refreshed the ACO certification standards back in 2021 and rebranded them as the Learning, Equity, and Patient-Centeredness or LEAP criteria, one of our goals was to emphasize the ACO model as a catalyst for learning and improvement among healthcare organizations. And this year, again, we saw indication of ways that ACOs are indeed functioning as learning organizations with structures and processes in place to support capturing and using data to enable improvements in patient experience, population health management programs, and clinical practice. So we were happy to see that the LEAP framework, with its emphasis on ACO mechanisms for learning and improvement over time, continues to be a good fit for the work that the ACOs are doing. Continuing a theme from 2021, we saw continued standardization of some of the larger, more complex ACOs to align their strategy and programming across risk contracts. In previous certification cycles, we had seen more of a federated approach from some of the more organizationally complex ACOs, which tend to have multiple contracting entities within their structures that hold and are responsible for managing performance under risk contracts. But lately, we've seen that these ACOs are increasingly pursuing ACO-wide approaches and strategies, demonstrating more systemness, if you will, and intentional consistency than in the past. We also noted that ACOs are largely continuing the core strategies and processes that we saw during certification in 2021. But we did see a variety of new initiatives, and some ACOs are in the midst of organizational changes. For example, the creation of new clinically integrated networks. This is not surprising. We did expect to see a fair degree of consistency with some evolution and innovation occurring as well. Finally, I did want to note an observation that ACOs vary significantly in their degree of progress on advancing health equity. Though to date, incentives and supports in certain payer contracts have helped in particular to advance data collection on race, ethnicity, and language, as well as metric stratification. Next slide, please. Before we turn to some of the content that we saw in ACO applications, I wanted to share a snapshot of what we're seeing with respect to the risk contracts held by ACOs. As part of the certification process, we do require ACOs to report some basic information about each of their risk contracts. With respect to the certified ACOs, the risk contracting landscape has been quite stable. Certainly between 2023 and the prior certification cycle in 2021, but even looking back a little bit further to prior application cycles. As we've discussed in the past, alternative payment methodology penetration is relatively high in Massachusetts. As you can see here, millions of base daters are enrolled in risk contracts. But there really has been very little growth in the number of contracts or covered lives over the lifetime of the ACO certification program. Noteworthy, however, is the prevalence of two-sided risk in certified ACOs contracts. Two-sided risk is nearly universal across those contracts. One other notable trend that I did want to call out is that we've seen a migration away from the CMS Innovation Center's flagship advanced Medicare ACO programs. Most of the certified ACOs that were formerly participating in those, for example, in the now concluded Next Generation ACO program, have moved into the Medicare Shared Savings Program at this point. Next slide, please. So one additional contextual point that I'd like to raise, one thing we strive for with the certification program is ensuring that certification is within reach of provider organizations of varying sizes, experience, organizational models, populations served, and locations. As you can see here, the sizes of the certified ACOs, meaning the number of risk lives attributed to them, do vary considerably. Some ACOs tilt more heavily toward mass health membership. Some have more of a mix of commercial, mass health, and Medicare risk business, and some have no traditional Medicare risk contracts at all. While we saw on the previous slide that the total number of ACO lives is roughly the same as it was 2 years ago, there was some shifting over that period between commercial and mass health risk lives, similar to overall enrollment trends in the market. While total ACO lives across all the certified ACOs have tended to be about a 50-50 split between public and private payer risk contracts, as of late last year, they were tilted a little bit more towards public payer risk lives, with 54% of ACO lives in a Medicaid or a Medicare risk contract. Next slide, please. So it might be helpful to take just a few minutes for a brief refresher on the LEAP standards for certification. Under Chapter 224, the HPC is charged with developing multi-payer certification standards for ACOs in the Commonwealth. Our payer-agnostic requirements focus on core competencies of ACOs as the trailblazers of care delivery transformation. One important aim of the program is to support payment reforms across both the commercial and the public payer markets while aligning with other ACO programs in the market like Mass Health's. The ACO certification program launched in 2017 when we issued our first 2-year certifications to 17 organizations around the Commonwealth. Notably, in 2021, as we prepared for the program's 3rd certification cycle, we made our first significant updates to the certification standards. Building on what we'd had in place before, we evolved the standards at that time to embrace the ACO model as a catalyst for learning and improvement among healthcare organizations, and to recognize the role that ACOs can play in advancing health equity in the Commonwealth. In 2022 and 2023, we certified 17 ACOs under these revised standards, which are known as the Learning, Equity, and Patient-Centeredness, or LEAP, criteria. ACOs receiving recognition under the LEAP standards must meet a set of objective criteria focused on core ACO capabilities demonstrating their dedication to patient-centered care, use of evidence-based and data-driven strategies to improve care delivery, and commitment to addressing long-standing health inequities. The standards include a set of prerequisite requirements pertaining to governance and risk contracts, compliance with a variety of legal requirements, but our assessment criteria are really the core of the program. These 5 assessment criteria evaluate the ways that ACOs deliver patient-centered care, foster strong cultures of performance improvement, use data to facilitate better decision-making and support improvement, deploy population health management programs, and take a whole person approach that includes supporting behavioral health integration and attending to patients' health-related social needs. And as you'll hear more about in a few minutes, ACOs are also required to report on their efforts to reduce health inequities. Now, as one example of what these criteria look like in practice, on the right sidebar here, you can see our data-driven decision-making criterion. This criterion examines ACO commitments to using the best available data and evidence to support improved clinical decision-making. To that end, applicants provide examples of processes or tools that they have adopted to make reliable current clinical knowledge available to providers. And they must demonstrate how they collect and offer providers actionable data, for example, on quality, cost, health outcomes, to enable high-value care delivery and improvement. ACOs primarily do this by providing examples of internal documents or resources that offer a window on how they have achieved these competencies. Next slide, please. Okay, so now we can turn to some of the content of what we saw during the certification process last year. One reminder I want to touch on, with limited exceptions, the information that is collected by the HPC through this application process is held confidential. The HPC does not disclose at the individual ACO level, without the consent of the ACO, any non-public information or documents that are submitted for certification that are clinical, financial, strategic, or operational in nature. However, we may discuss and report on certified ACOs using aggregate or non-attributed information, which is what we'll do today. Now, first, it's worth noting that many aspects of ACO strategies and operations, their approaches to meeting the criteria I just described, did not change from the previous certification cycle, which again is not unexpected, given that in many parts of the application, we're looking at longitudinal processes that are likely to persist over time. For instance, our standards require ACOs to describe how they risk stratify their populations for the purpose of managing population health. Those methodologies, which tend to rely on algorithms based on data related to factors like utilization, cost, diagnoses, those remain largely the same as they were in 2021. Similarly, the key strategies that ACOs use to understand their patient population's experiences, their preferences, which are primarily patient experience surveys and PFAC engagement, have remained consistent as well, as have the performance feedback mechanisms they use to offer providers actionable data for improvement. These are things like dashboards or scorecards that allow for performance comparisons. We found that in fostering cultures of improvement, certified ACOs continue to commonly rely on regular cross-functional meetings that are dedicated to identifying opportunities to improve performance on cost and quality metrics. Many of the ACOs regularly convene clinical, operational, and business leaders from around the ACO to discuss performance improvement goals and opportunities, strategies, and activities. And this infrastructure for reviewing organizational performance, normalizing continuous learning, and spreading promising practices is relatively mature and well-established at this point in many of the ACOs. Additionally, certification requires that ACOs seek to integrate behavioral health into their care delivery models. Certified ACOs collectively identified 47 priorities shaping their integration strategies. For instance, supporting co-location or building PCP capacity to manage low and moderate behavioral health conditions within the medical home. But many of the priorities and targets identified last year are consistent with strategies that the ACOs detailed in 2021 as well. Next slide, please. Well, as we discussed earlier, ACO certification requires commitment to using the best available data and evidence to support improved clinical decision-making. And all of the certified ACOs were able to show how they do that. They, in many cases, retain the same processes or structures for facilitating learning among providers that were in use in 2021. But they were required to show recent developments or updates in their applications last year. All are continuing to curate and disseminate tools or information to educate providers and decrease practice variation. Some ACOs have standing bodies that create or update materials, programming for clinicians, for instance, new care guides for select conditions, or periodic updates to evidence-based protocols. Others have created decision support tools, often building them directly into the electronic health record. Some ACOs convene learning opportunities around topics like evidence-based clinical initiatives that the ACO is sponsoring, or educational sessions aimed at quality improvement. And some have launched other interventions targeting low-value care or otherwise attempting to reduce practice variation. For instance, one ACO designed a series of interventions, including new electronic best practice advisories and clinician outreach strategies to support an antibiotic stewardship initiative. Next slide, please. ACO certification also requires that ACOs implement programs to coordinate care, manage health conditions, and improve the health of their patient populations. The certified ACOs reported on dozens of population health management programs, including the discrete goals against which the success of PHM programs are judged, and a description of the evolution of PHM programs over time as ACOs learn from experience. This time we saw that some PHM programs from 2021 were ended and others were created, but for the most part, there's been continuity in programming and goals and targets. But even with that continuity of programs and objectives, we did note some new developments. We saw increasing mentions of health equity as an explicit aim of some programs. This was still true of only a relatively small number of PHM programs, but this is a notable shift from 2021. In line with the Learning Health System framework, we saw that ACOs iteratively modify their programs based on performance relative to their goals. Numerous ACOs have made process improvements or tweaks to their programs, for example, in shifting their staffing strategies. We also saw more programs aimed at explicitly meeting population-level contractual ambulatory quality targets, for example, around diabetes, hypertension, or colon cancer screening metrics. Finally, we noted an apparent scaling up of many PHM programs relative to 2021, either in terms of larger enrollment, more aggressive performance targets, or additional program elements. In some programs, we are starting to see PHM take the form of broader interventions for managing large swaths of primary care panels, for example, all patients with diabetes, rather than more narrowly targeted interventions. Next slide, please. HPC certification also requires that ACOs collect and use information from patients to deliver and improve patient-centered care. We require ACOs to show us how they use the information gathered on patients' experiences and their preferences to influence care delivery. And we saw a variety of approaches, with this information informing activities ranging from organization-wide projects or trainings to ongoing process improvement work at the practice level. Some general patterns were apparent this cycle. Some ACOs have developed processes to support ongoing analysis of patient experience data, identify new areas for improvement, and generate interventions in response to results as necessary. Some of these processes involve structures like patient experience steering committees, or the use of lean performance improvement scorecards. Other ACOs use patient input to inform new or ongoing initiatives that are already being pursued by the ACO. Others have in place processes for offering individualized feedback or coaching to providers, or providing direct outreach to patients who have identified areas for improvement. In some cases, the ACO is taking a role in standardizing processes for data collection across practices and setting ACO level priorities or goals, while at the same time providing opportunities for local design and implementation of patient experience improvement efforts. Next slide, please. Now, one theme we observed during this certification cycle was a consistent effort across many of the ACOs on what we're broadly describing here as process improvements. And we've called out a few areas where we've seen that. One is in a variety of ways that ACOs have worked to improve their operations. Examples of this include an ACO that established a new centralized team of nurses to streamline and standardize triage in the handling of all clinical questions from patient calls or patient portal messages, and an ACO that's experimenting with expanding the scope of certain non-clinical case management staff to reduce administrative burden on nursing staff. Another area where we see this is in relation to health-related social needs screenings. Certification requires that ACOs seek to integrate social supports into their care delivery models. We've seen that the certified ACOs have implemented health-related social needs screenings and referral activities in primary care. But last year, we saw a greater effort to standardize materials and workflows to ensure a consistent experience across ACO participating providers. This includes creating guides for primary care providers on how to conduct screenings and how to respond to positive screens, as well as standardizing workflows for following up after social needs are identified. ACOs are also making large-scale organizational commitments to ongoing improvement. Some are adopting formal process improvement methodologies like Lean, while others are pursuing engagements with population health management companies to help them reimagine their operations. Next slide, please. Last year, we refocused the certification program's health equity requirements onto 3 opportunity areas that we had identified from our review of the 2021 ACO submissions. We asked ACOs to report on their progress in each of those 3 areas. And those are data-driven interventions, or how ACOs are collecting socio-demographic data and using it to identify and design interventions to address inequities. Patient engagement, or how ACOs are engaging the patients impacted by that inequity as they consider how to design interventions. And strategy, or how ACOs are embracing at the organizational level a responsibility for improving health equity. Now, as we might have expected, much of the ACO's activity to date has focused on collecting data, primarily on race, ethnicity, and language, and beginning to use that to stratify metrics to identify inequities. Some ACOs have already gone a step further and begun designing or implementing interventions to address inequities that they've identified in their data, but many ACOs have not quite gotten to that point yet. About half of the ACOs have begun to engage patients in some way in the design or implementation of equity-focused interventions, though the nature of those engagements varies considerably, from communication with PFACs to interviews with patients experiencing inequity. 3/4 of the ACOs reported having made and or operationalized strategic commitments to improving health equity. Some of these focus explicitly on identifying and addressing specific inequities, while others include things like commitments to addressing factors like racism and health-related social needs, or a variety of diversity, equity, and inclusion or recruitment activities. Next slide, please. I wanted to end by noting that there are both nascent and ongoing efforts by ACOs in the health equity space that provide a lot of opportunity going forward. As we heard earlier, the Commonwealth is focusing its health equity efforts on certain areas, namely the drivers of inequities in cardiometabolic and maternal health outcomes. Certification offers a window on some of the health equity focused activities of ACOs. And from what we saw last year, there is quite a bit of momentum in those priority areas. All of the ACOs are starting to stratify metrics using data on factors like race, ethnicity, or language. And we saw considerable emphasis on identifying disparities in hypertension and diabetes indicators in that work. Similarly, among those ACOs that have begun taking some next steps to try and act on inequities, we again saw some recurring themes around focusing in on inequities in hypertension, diabetes, or maternal outcomes. That includes an ACO that's been working on a blood pressure control pilot to target racial inequities and outcomes for hypertensive patients, and an ACO that's focusing on racial inequities in severe maternal morbidity. So the state and many of the ACOs are moving in a similar direction, which provides some opportunities for those efforts to begin to complement and build on each other going forward. I'll end with that thought, commissioners, but I think we have plenty of time for any questions you might have on the ACO certification program. So thank you.
Thank you so much, Mike. It's a rich field of data that we're developing here, so thank you. I see our chair has a question, Deb.
Yeah, thank you so much. Thanks for all of this, Mike. A lot to think about. A lot is going in a good direction. Two questions. When you reference the fact that the number and scope of risk contracts is decreasing, my question is, do we have any insight as to why? And then my second question is, on the equity data, is this focused on commercial patients, or is this focused on all of the patients in the ACO's practice? I'm just trying to get a sense of when the ACO is saying that they're proposing pilots or they're working on these issues, whether they're doing those for certain populations or across the board.
Yeah, great question, Chair DeVoe. On your first question, with respect to the risk contracts, I wouldn't say that we've seen them decreasing. It's more that there's been sort of a leveling off. And so within the ACO certification program, I think we have about 3 million covered lives across the ACOs that we certify. And that's been pretty consistent for the past couple of years. And so it's not so much we're seeing any erosion. It's just, we seem to have reached a plateau for some time at this point. On your second question, it varies a little bit. So we've tried to dive down a little bit this year and look at how ACOs are implementing health equity interventions across different populations. And so much of this activity is happening in the mass health space, but ACOs have kind of moved beyond that as well and are also beginning to stratify metrics with respect to their commercial and their Medicare populations as well. I think with respect to interventions that have been launched at this point, which are not entirely common among the ACOs quite yet, our sense has been that those are driven a bit by incentives and payer contracts. And so since mass health has leaned so heavily into some of its equity incentives and some of its work in that space, I wouldn't be surprised if mass health is kind of the main driver at the moment. But we have seen commercial payers also becoming more active in this space as well.
Thanks,
That's
Mike.
really helpful. I think it'd be useful to think about in the future, really understanding which populations the interventions are, implemented for, because it'll help us understand whether there's whether the actions on equity have to be linked to incentives in order for them to, get the priority that I know. I'm sure all the organizations are interested in giving them, but I don't want there to be any confusion that these are being implemented across the board as we're reporting on it, publicly. Yeah. So great, thanks, Mike.
Like picking up on Deb's point a little bit. I remember going back early on, I think to the 2017 standards, that we didn't really see change in how the ACOs were paying providers. So, there were risk contracts in place, but the actual provider relationships were still largely fee for service. Do we know if that's changed at all over time?
We've collected some information on that in the past, and one of the ways to meet one of our criterion does allow ACOs to report on sort of internal payment methodologies, but they can also satisfy other ways. So we don't have information about all of the ACOs in that space. But there definitely are ACOs that have implemented sort of internal and frameworks for, changing a little bit of the compensation of providers to link their incentives with the broader external contractual incentives. We can't say for sure exactly if it's ubiquitous across all the ACOs, but it's something we have seen in some, certainly.
Thanks.
Are there other questions for Mike? Hearing none, then, Mike, any final thoughts or comments from you?
No, thank you all for your attention today.
Okay, thank you for a great presentation. Kelly, anything from you?
I would just reiterate what Mike said. Thank you so much for your attention to both of these topics, and we'll look forward to being back with more.
Fantastic. Colleen, anything from you?
No, thank everyone for 3 technically wonderful meetings. Of course, everything is on the website, including the data points that we released earlier today with the interactive Tableau graphics. So I encourage you all to check that out. We meet again in May, but before that, we've got an advisory council in February and the benchmark hearing on March 14th. So look forward to seeing you all before then and then. Appreciate you, Chair Blakeney, and everyone who attended today.
Well, thank you all, and thank you for the staff for, as always, preparing excellent presentations. And I look forward to seeing everybody at our next opportunity. So have a good day, and